Welcome everybody to the MGH Brain PBM rounds. Today is June 7, 2024. I'm Paolo Cassano, and it is my great pleasure to introduce today Phoebe Chan, Dr. Phoebe Chan, our very own from Mass General here at Martinos. She is an instructor at Harvard Medical School, and she is also a bioengineer by training. She will be talking about the effects of photobiomodulation on resting state functional connectivity following moderate traumatic brain injury. Phoebe, welcome, and please take it away.
Okay, thank you, Alva. So my name is Phoebe. I'm actually from Athinoula Martinos Center, Mass General, as Paulo mentioned. And first of all, I would like to thank Dr. Cassano to invite me to talk in this clinic round. So today the topic of my talk is the effect of the photobiomodulation on resting state functional connectivity following moderate traumatic brain injury. I'm going to share with you some of the preliminary findings on the changes of the resting state brain activity after receiving low-level near-infrared light in patients during the acute and subacute phases following moderate traumatic brain injury. And this is the collaborative work between the Martinos Center for Photomedicine and Radiology at Mass General. So the work is recently published in the latest issue of Radiology. If you're interested in it,
Phoebe, you're not sharing your screen.
Oh.
Just to make sure. I know we shared before.
Okay. Yeah. Possible. Okay. So this is the work we recently published it in the latest issue of Radiology. So if you are interested in the issue, the details of the papers and the paper can be downloaded at this website. TBI, traumatic brain injury. So traumatic brain injury is a global health problem. Some individuals following traumatic brain injury may suffer with multiple post-injury symptoms like headache, dizziness, loss of concentration, and memory problems that may last months, years, or even over lifetime. The psychiatric and neurological conditions are frequently found in the individuals following TBI. Here is the figure extracted from the study analyzing hospital-based registry data in the time period from year 2000 to 2015. And the authors reviewed the records, the medical records from 4,000 patients with a mild TBI, 4,000 patients with a moderate to severe TBI, and 4,000 individuals without head injury. Compared with the group without the head injuries, the results actually show the cumulative increased risk of some conditions like depression, anxiety, sleep disorder, seizure, or even ischemic stroke. It is higher it is significantly higher after traumatic brain injury. So persistent post-injury symptoms and conditions following traumatic brain injury may lead to lifelong disability. However, today, evidence concerning the benefits of the non-pharmacological interventions to post-injury symptoms is very limited. Low-level light therapy. In animal studies, transcranial low-level near-infrared light has shown multiple cellular effects that summarized here. It is able to increase the blood flow, enhance the angiogenesis, and reduce the inflammation. So basically, a lot of things. And in several case studies, Dr. Margaret Nasher reported an improvement in the cognition and depression after receiving light therapy in patients during the chronic phase following TBI. And in the previous literature, we know that the first few weeks following TBI is believed to be the critical window for neuroplasticity and also the window for treatment application that may affect the recovery process. Therefore, in our trial, we explore whether there is any impact of acute low-level light therapy on brain activity following moderate TBI. So we use different MR imaging metrics to study the brain responses to light therapy. One of the parameters is the diffusivity in white matter. And the work is actually published in the JAMA Network Open. So in this study, we reported an alteration in white matter, in white matter of the, say, for the patients after receiving light therapy. So imagine that the white matter are the cables to transfer the signal from one brain region to another. So alteration in the white matter means the alteration in the structural connection. So if you are interested in the details of this part of the study, so the paper can be downloaded at this website. Another imaging metric that we use in this trial to look at the brain response to light therapy is the resting state functional connectivity. We looked at the low frequency spontaneous fluctuation in the brain using functional MRI when the patients are in resting condition. Resting condition is that you just mind there without doing anything, without performing any task, but awake, not sleeping. And the BO is the technique that we use for the functional MRI imaging. And we measure the BO signal changes in the whole brain when the patient lies in the MRI scanner for 10 minutes in the resting condition without performing any task. But they have to keep themselves awake. This is one of the tedious tasks, and keep yourself awake in the scanner for 10 minutes. And we then measure the correlation of the BO time series between different brain regions. So here is an example. In the brain, we extract the time series of the BO signals in 3 different brain regions. And these are the time series, the region for the time series for the region here, and the time series for the region here, and the time series for the brain regions here. So if the 2 brain regions, if they functionally communicate with each other, they will show the strong correlation and then form the network. So the color here indicates, the same color here indicates that they are within the same network, the brain regions within the same network. And previously, Dr. Randy Buckner and his team reported multiple resting state networks for different brain functions, like so much motor, also attention, visual, salience, default, and frontoparietal. And so in the last 2 decades, scientists often use this connectivity approach to study the abnormal brain function. Okay, resting state functional connectivity in TBI. So in TBI, we usually use resting state functional connectivity to study the neuronal disruption. And increased connectivity among the brain regions are often observed in TBI patients. The increased connectivity has been suggested as a tightly synchronized brain activity in response to the damage neurobiological substrate at risk. So here we have an example of 2 studies. In this group, Nakamura and her team actually studied the connectivity in a severe TBI patient 3 months post-injury and also 6 months post-injury. The connectivity actually compare with the healthy control at the time point which get the interval of the 3 months. So what I see is that in the 3 months post-injury, there is an increase in the connectivity when you look at the say the intensity of the connectivity matrix here for the patient and also for the control. Also in Palacios group, they actually studied the resting state connectivity in chronic TBI patients. They got 20 TBI patients versus 17 healthy control. They also see that the medial frontal and also at the frontal pole as well, it shows the increase in the resting state connectivity. Okay, here is the study protocol of our randomized trial. So we basically recruit the patients from the moderate TBI at the emergency room of Mass General. And the inclusion criteria for these patients is that the Glasgow Coma Scale TCF scale of 9 to 12 or 13 to 15 with normal CT findings. And after screening for the eligibility, the patient will went through the enrollment procedures, and also they will be randomized to either the light treatment or sham treatment arm. And so all the members in the study team, because this is a randomized double-blinded study, all the members in the study team were blinded to the treatment, except the people who are responsible for the randomization and treatment administration. And so for the light treatment, within 72 hours after the injury, the first treatment was applied. Okay, so for the light treatment arm, we apply the light treatment, and for the sham arm, we apply sham treatment. And the second and the third treatment will be applied, say, at the interval of at least 12 hours from the first, say, at an interval of the 12 hours. And then, so all 3 treatments have to be finished within the first week of the injury. That is the day 7. If we consider day 0 as the time of the injury. And so in terms of this MR scan, we schedule 3 MR scans to follow up the patient. And the first scan is actually happened within the first week of the injury, and which is we consider it as the acute phase of the injury. And the second MRI scan was scheduled during the subacute phase, which is what around 2 weeks after the injury, which is day 14 to day 21, because of the scanner schedule and also the patient availability. We allowed 1 week to say get them into the scanner. The last scan, the third scan, is actually scheduled around 3 months post-injury, during which we consider as instead of the chronic stage, we consider as the late subacute stage of the recovery from the TBI, moderate TBI. And we also include another group of the healthy subjects. The healthy subjects, they don't have the history of the head injury, and no treatment was applied to these individuals, and they were only scanned once. Because if we go back to one study before this study, they actually studied the resting state connectivity at these 2 time points, and they didn't find a significant difference for the healthy control in terms of the resting state connectivity over, say, 3 months. So this is the helmet we use for treatment. And So here are the parameters of the infrared light. And in the treatment arm, you can see that it's possible. It's very small of the LED here. In the treatment arm, for all of the patients, when they receive the light treatment, so the LED will be on. And for the sham treatment, actually the LED were off. So these are the procedures we use to analyze the resting state functional MRI data. After the pre-processing of the resting state functional MRI data, the time series for each brain region was extracted. So this is one of the sample time series from one brain region in a representative subject. And we use the software-free server to do the brain segmentation. And altogether, 82 brain regions were segmented. So time series from each of the 82 brain regions was actually extracted. As we are interested in the low-frequency spontaneous fluctuations when we do the resting state functional connectivity, we usually look at the low-frequency fluctuations. So we applied a low-pass filter to the time series. And after filtering, you can see that a lot of the high-frequency signals have been disappeared. And the bandpass filter that we use is actually 0.008 to 0.125 Hz, which is consistent with the typical bandpass filter that is used in most of the previous resting state connectivity studies. And then we perform the correlation analysis. Correlation analysis for each of the brain regions. We do the correlation analysis of the time series from that region to the other 82 brain regions. So you can imagine that if I take the seat over here as one region, and then it will correlate with 81 different other brain regions in the brain. And then we will repeat this procedure for each of the brains. So altogether, that will be 3,321 brain region pairs that we have to do the correlation analysis for each set of the brain. And we'll present the result in the connected because there are so many connections for even one single set of the brain data. So you can see that this is the connectogram, what we call connectogram for representative healthy individuals. So you can see that here it shows different labels for the brain regions, the frontal area, the insular area, limbic, temporal, parietal, occipital, cortical on the left side and also on the right side. And you can see that for the healthy individuals, it got more symmetry in terms of the connection. And this is the consort diagram showing the patient number at different stage of the trial. So you can see that this is actually a very difficult study, I can tell. And my teammates, Gabby Johnson and also Aman, they actually stay in the emergency room to screen a lot of the patients. And then you can see the numbers, 4,200 patients to be screened in the emergency room, and ultimately only 68 participants with moderate TBI can be randomized. So most of them actually not meeting our inclusion criteria, and a portion of them actually declined to participate in the study. So that actually is a lot of work to do in this study, especially for this part of the subject enrollment and recruitment, screening, everything. So they actually work almost 24 hours for 7 days ultimately, with a few dropouts in each stage. And we have the data from 17 might-treated patients and also 21 sham-treated patients to analyze. And on the other side, we have healthy individuals. Healthy individuals is that one of the major inclusion is that they don't have the history of head injury. And we also screen them with some other conditions. So for example, the respiratory condition, cardiovascular condition, and also for the presence of the migraine. And we make sure that all these healthy individuals are clean. So these are the characteristics of the patients and healthy control. And when we do the randomization and when we do the screening and enrollment, we try to stay balanced on the age and gender of each study group, like the sham group and also the control group. Okay, so this is the most exciting part, the results. And first of all, I try to show the comparison, the cross-sectional comparison between the patients and healthy control. I arranged the TBI recovery phase in columns and the sham and might-treated patients in rows. So you can see that here is the cross-sectional comparison between the sham-treated patient and the healthy control when the patient is in the acute phase of the moderate TBI. So this is the sham compared with the control with the sham-treated patient during the subacute phase. And this is the sham-treated patient during the late subacute phase versus the control. The same thing happens for the light-treated patient. This is the cross-section comparison of the light-treated patient during the acute phase versus the control, and might-treated patients during the subacute phase versus control. And the last one is light-treated patient during the late subacute phase versus control. So without going into too much details, and then so based on just simplified visual inspection, you probably noticed two features in here across all these circles. So the first one is that you can see that consistently these connections appear in all 6 circles. This one here, 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 and here. Okay, so so this actually is the connection between the left superior frontal area and the right superior frontal area. And the second feature that you probably noticed is that, especially this one, you can see that the connection is more symmetrical and on the left and right side. So so this one is actually the cross-section comparison of the resting state functional connectivity in a light-treated patient during the late subacute phase versus control. So you can see that one more minor feature that you probably noticed in this here is that this one looks more similar to this one. And this one is actually the resting state connectivity in the sham-treated patient during the late subacute phase versus the control patient. And this one is actually the light-treated patients during the acute phase versus the control. You can see that it seems to be asymmetric on the left and right side connection. So let us go over to the temporal comparison. So here are the temporal comparisons. Right now, for the temporal comparison, we focus on the patient only, okay? And then here we show I arrange the temporal comparison between the acute and subacute phase in rows in the first column, sorry, in the first column. And temporal comparison of the resting state connectivity between the okay, so in take it, let me do it again. And in columns, we arrange the light treated patient in the first column and the sham treated patients in the second column. In the rows, we arrange that the temporal comparison between the acute to subacute phase in the first row, and the second row, the bottom row, is actually the temporal comparison from between the subacute to and the low subacute phase. So we can see that if we look at sham treated patients only, we can see that basically the resting state functional connectivity it decreased from the acute phase to the subacute phase in 4 connections. And then it bounced back with 13 connections increased from the subacute phase to the late subacute phase. And then we look at the light patient. Light patient is something like say continuous increase. Is that we find that 14 connections with the increased resting state connectivity from the acute to subacute phase, and then continuously increase with only say 10 connections, not many, but comparable number of the connections in here. So you can see that the resting state connectivity here is for the sham treated patients like a V-shaped syndrome, and then for the light treated patients, something like mania, at least not going down in the subacute phase. So when we try to compare the light treated patients and the sham treated patients, we find that 7 connections actually in the acute to subacute phases changes. We see that the resting state connectivity actually changes in these 7 connections. So, but when we try to compare the subacute to late subacute phase, and then we didn't see any significant changes, a significant difference between the light treated patient and the sham treated patient. So here, so in the first cross-sectional comparison, we can see that the natural feeling of the patient following the traumatic brain injury is like the connectivity change. The connectivity decreased from the acute to subacute and then increased during the late subacute phase. And when we try to compare the temporal changes in the light treated patient and sham treated patient, we find that there is a greater acute to subacute resting state connectivity changes in the light treated patient. So this actually suggests some impact of the low-level light therapy, and the increase in the resting state connectivity after the low-level light therapy is consistent with the resting state study in patients, in some of the previous studies in patients with a chronic stroke and also dementia. So hyperconnectivity between the bilateral superior frontal regions in the TBI patient, irrespective of the recovery phases, that it actually implies the importance of the superior frontal gyrus in the interhemispheric baseline communication following injury. So because the major improvement in the life functioning may last for a year following the injury So our findings here only up to late subacute recovery phase. It may be too early to define the therapeutic role of the light therapy for the post TBI symptoms. And notably, and then one piece of the information that I didn't display in this slide deck is that the Rivermate post-concussion symptoms questionnaire score that we measure. We usually use that questionnaire to measure the severity burden in the TBI patient. And then we didn't find any significant difference between the light therapy patient and the light treated patient and the sham treated patient for that score. So we don't have sufficient evidence to say that based on clinical outcomes. So light therapy is truly can treat the patient. We only in this study we only show that the impact of the low level light, low level in infrared light on the resting state connectivity. So to conclude what we found, so our findings basically confirm the impact of acute light therapy. We are not studying the chronic state, the acute light therapy on the resting state neuronal circuit during the first 3 months of the recovery from moderate TBI. And definitely future study with a larger sample. And also the correlation of the imaging parameters with the clinical outcomes like the other psychological scores will help to determine the role of the light therapy in the moderate TBI. So here is the team who contributes so much in this work. And especially I want to acknowledge Aman, Maria, and we call her Gabby, and also Jonathan. They worked so hard to screen and actually recruit the patients in the emergency room. So that's it for my presentation. I would prefer to have more time for the discussion.
Thank you. Thank you so much, Phoebe. This is quite an amazing and very inspiring talk and incredible endeavor as well. If you want to stop sharing, we can see the different people in the audience, I guess. And I know there are some questions. I would ask people to come about and ask your questions. Okay, see Lou. Go ahead.
I think this is actually a very important work because a lot of the work that's published on PBM and TBI has been on chronic stage. Mani is here. Mani has done even more than chronic stage. It has gone into degenerative stage of CTE. So that's very, very interesting. I just wanted people here to know that there is, there's this work done with Phoebe here and the previous group at MGH on the acute stage using DTI. I thought that's very interesting. In TBI, yeah, the natural recovery is always there. I think that's shown. Actually, when you look at a late subacute, it's almost like there's not a lot of difference. And so we have to respect that, but looks like, further biomodulation does have an impact. But what's happening quite a lot is, the work we do with Mani at Boston, and I think maybe there's a representative from University of Utah, is looking at chronic long-term over a year. There is data, you probably know there's data coming out of Anne McKee's research that repetitive head impact over a long period of time, leads. Sometimes it doesn't even show as in imaging with DTI, but in the long term, it does lead to chronic symptoms, in some cases, even to CTE. So there is some distinction here between acute stage, even subacute, up to 6 months, and long-term repetitive head injury, as we see in contact sports like football, hockey, and now we're looking into the military side too. There is so I think data is going to come out. I'm not going to speak on behalf of Utah to show both imaging and clinical outcomes for long-term, long-term symptoms that photobiomodulation will actually show pretty strong evidence of recovery. So I think there'll be more work coming up. We look forward to that.
Yeah, that would be great if there will be more data to support the photobiomodulation at the clinic stage as well. Yeah.
Before on these questions, I'll just read one from the chat as well. Could it be hypothesized that one side of the brain is healing faster due to the shift to a more asymmetric connectivity pattern in the LLT treated group? So do you think that the asymmetry indicates that one side heals faster?
It is difficult to say because we didn't have any physiological data to support. And then the thing is that we can only observe that the symmetry of the pattern, whether it is symmetrical or asymmetric. But when we try to put this into the statistical analysis, then we have insufficient evidence for that cross-sectional comparison. Yeah.
Okay, thank you. Hanli?
Hello. It's very impressive work, very important work. And then also published in this high impact journal, which really gives a lot of significance for the field. So that's my comment. But I have a few practical questions. So first of all, can you go back? I guess, no, let me ask others and then we go back to that sheet. So what is the frequency range do you use for your filtering? I mean, MRI is already pretty slow in terms of frequencies, but then it looks like from your data, you also filtered even lower in the frequency range. So do you remember that? What's the frequency?
The frequencies that the bandpass filter we use for the resting state connectivity is 0.008 to 0.125. We use the exponential of 2 to do that. The filter is exponential 2.
So that is in your paper, I assume, right? I'll check that.
Yes, it is in our paper, and then it is because in the previous literature of previous resting state connectivity literature, you've already found that the bandpass that they frequently use is 0.01 to 0.1. So it is more or less similar. It's only that I have to be more precise. When we try to use the filter at an exponential 2. Yeah.
Now, do you really think hair would not really matter? I mean, because we also think hair, because the helmet will be just put on the head and then people have different thickness of hair. Do you think hair would make some difference?
Yeah, we actually consider that part in our study. But given that you can see that the sample size ultimately we can only get total of 68 patients. So in our analysis model, we cannot incorporate so many confounding factors. So here is one of the things we actually got the data, but unfortunately we cannot put it in the analysis model because it will create an overfilling of the model. Yes.
So it does mean that if someone like your hair, for example, is pretty dark and thick, that would affect your effectiveness of the treatment.
Yeah, we actually collect the hair color data, but we didn't separate them to look at how the hair affects the modulation and effect on the resting state connectivity. Yeah, yeah.
Now I have a few quick questions. So two more. Another thing is that does the location of TBI affect the treatment? I mean, some of them can be deeper, some of them can be shallower. So what do you consider that?
Yes, that's a good question. Actually, it is very variable. This is the tedious part of the TBI study. I'm sure that Margaret agree with that.
Mm.
Yeah, it varies from one location to another. And that actually has a large, patient variability. And when we look at the data, we carefully look at the individual changes. And then when we try to do the statistical analysis, then we try to look at it carefully, see whether there is any false positive changes.
Thank you. So one last one. In your drawing with that circle for connectivities, you have two numbers. You have two numbers written on the top. Can you share that screen? I mean, for the connectivity, it has two numbers. Each circle has two numbers on the top. So what are those two numbers?
The two numbers is actually the first number, the red color, is actually the number of the connectivity that shows the significant increase. And then the blue numbers is actually the number shows the number of the connections shows the decrease in the connectivity. Yeah.
Okay.
Yeah, we try to summarize it because when we look at the connectograms, it seems to become scattered. And then I feel that you also notice that for some of the papers, and when you look at the connectivity, it's just like a spider web.
Yeah.
Use the number to summarize the number of connections. And so in our preprint, we also have the nodal centrality as one of the metrics to quantify that. And then so.
Thank you. Got it.
Great. I see Joe is waiting. I'll just ask another question here from the chat as well. Do changes in functional connectivity correlate with changes in behavior or RiverMed pod concussion score?
Yeah, so that is also a good question. So we try to correlate the functional connectivity with RiverMed post-concussion score because of the high variability and also the subject report of the RBQ score. And first of all, for the RBQ score, when we try to compare the sham and the light-treated patient, and then we didn't see the significant difference because of the high variability. And this is also, we also include a figure showing all the individual changes of the RiverMed score. But you can see the trend that it seems to say, for the light-treated patients, they tend to have the slightly lower RiverMed score, that is the better condition. And so going back to the question of the correlation between the functional connectivity and the RBQ score, because of the RBQ score got a large variability. So when we try to do the correlation, we didn't find the significant correlation. Yeah.
Okay, thank you. Joe?
Thank you for the great study. And the acute TBI is really hasn't been studied at all. Good job. And MGH PBM for getting us this explained to us. I don't really understand resting state connectivity, but my question is one to Paulo. You're the dosimetry expert in the room right now. From my opinion, would you give a comment on how much joules dose, however you want to explain that to the group? How did we do with our acute TBI people as far as their dose? And secondly, Phoebe, I'm not sure if I heard incorrectly because your microphone was a bit low for this complicated talk, for my ears anyway. But did you not say that higher connectivity was a bad thing in acute TBI or post TBI? What did I miss in the beginning? Can you explain it to me?
So Higher connectivity actually means higher correlation strength. High correlation strength that means simply speaking is that these two supposedly have two brain regions. If they have the high correlation strength in terms of the spontaneous fluctuation, that means they functionally talk to each other. They can talk through a long route, long neural pathway or short pathway. We don't know, but at least they communicate with each other. Yeah, tightly. Yeah. And then going back to your question is that the dosage of photobiomodulation, and fortunately my background is the imaging background. Although I'm a biomedical engineer, but so this device, this helmet is actually designed by Martinos Center. And the incident fluence that we use is something like 1.3 joules per square centimeter. And then so according to what I heard from the colleagues is that this is kind of the conservative dose to in the transcranial photobiomodulation. This is what I heard. I possibly wrong. And then it is something which is adequate enough to pass through the scalp to the brain, so as to make the whole brain back in the neural light. Yeah.
Thank you, Phoebe. Did I get this right? 1.2 joule per square centimeter? What can you repeat the the joule per square centimeter?
The 1.3.
1.3. Okay. Thank you so much. And Marnie.
Okay, thank you. This was a great talk. I'm really interested also in acute TBI. There were sort of three parts I think I wanted to mention. Yes, there's just great variability in traumatic brain injury. And I think everybody accepts that. And it's really not easy to localize what's going on at all. And as most people know, when they get to the emergency room and they do a CT scan right away, they want to know if there's bleeding, hemorrhaging, and so on. That shows up really well on CT scan. But for the most part, there's nothing else to see. I mean, on the structural imaging. And so it's really good we can go to functional connectivity. I mean, you can even get TBI from blast waves, you know, the compression difference in the air pressure in the blast TBI soldiers. So it's really a bilateral, it's a bilateral problem. And I don't know if anybody studied, I mean, if they knew the impact where it was coming from, maybe it'd be more on the right, but then it's go right, left, because the brain's gonna slosh around in there anyway. So I don't think that you localize that very well. I did want to know if when you analyze and you show these beautiful connections going wherever, did you get it down to a finer level, even on individual cases, that you had better functional connectivity, for example, for the salience network, which would be, you know, anterior insula, anterior cingulate, that sort of connection, because we found increased connections in the salience network in particular in our research with the football players. And then there was increase in the increased connections within that salience network with executive function. I mean, it was unbelievable. These correlations, when you put behavior, executive function, for example, and the behavior on the color word interference test, for example, and you compare that, you correlate it with these connections. The salience network is just incredibly powerful. So I wondered if you broke it down to a given network, or even we didn't see changes in default mode network, which you would have thought would be your first choice, but we saw it in the salience network, important for attention. Internal or external attention. So I was just curious what happened with if you did that. Or maybe I missed it. I don't know. Just let me know.
That's good. And then actually we looked at different networks. I think at the very beginning of the analysis stage, and then we used to break it down into different networks. And then we tried to look at the individuals, how different networks interact, and then also how they respond to the light. And then it seems that because we got that many data is only say 17 versus 21. So it seems that for each network, it seems to be only a couple of stuff. So it's kind of scattered. So that's why it is kind of difficult to say summarize with some concrete findings of the photobiomodulation. It seems to be, say, if we have the, say, the lesions is already heterogeneous, so heterogeneous, and we cannot group them in terms of the lesion, in terms of the response, and in terms of the network in 3 different parts. So
Okay.
that's why we ultimately try to group them together and then separate it into different brain regions according to the loop, the cerebral loop instead of the network. Yeah.
Okay, I see. And I was curious, maybe you could look at your data because we only had 4 football players where we were able to do this, and we couldn't use them as a group either. So maybe if you found somebody who did really well, you could just look at that as a case study, and then somebody who didn't do so well and use that as a case study. So that would be really interesting to find out. If you find a network, that would be good. Yeah, salience is the one we found out to be across all the cases. We really had 3 functional. We had 3 cases that had, resting state functional imaging, but every single one had a correlation with the salience network and something. And the PTSD correlated really incredibly. And pain also was highly significant for the salience network. But, we can talk about that later. Thanks. It was very, very good. I thought it was wonderful. So thank you very much. We enjoyed it. Mm-hmm.
Thanks, Marnie. Hanli?
Yeah, if I have another chance. So MRI is definitely a good imaging machine to use. And then since you are saying, Phoebe, that you're from a bioengineering background, so do you have everything or studied a possibility to use a EEG for study brain network rather than MRI? Because EEG is much cheaper relatively and more convenient. So what's the opinion do you have for that?
Because if for this group, this cohort, yeah, I think because I walked through the whole procedure of data collection, and then I think that EEG possibly is, although it is kind of the best side too, but the thing is that it possibly takes a lot of time to set it up, and then some of the patients that we didn't collect a lot of say clinical outcomes in this study. Is one of the major reasons is that they are still especially in the first scan, they are still in the acute state. Some of the patients cannot stay in the scanner so long. So that's why if we are using the EEG, then possibly the dropout rate will be even higher.
Yeah.
And then yeah, I love to use the EEG, but the thing is that for this group of cohorts and a lot of the constraints. Yeah.
And also quickly, for sham group, did you tell them, I mean, it's a double blind or a single blind?
It's double blind. Actually, so after they have the helmet, they have no way to see what is going on in the helmet.
Okay. Thank you.
Yeah. Thanks.
Marnie, did you have another? You're muted.
I did, because we use that same helmet with our Go for Illness study published, I don't know, a long time ago. And it's near, I just wanted people to know it's near infrared only. I mean, at least the ones we ended up working with. Yours has red though, right? You are not. I thought red and near infrared. I see. When we worked with it, we were so worried that they would, I see. So you absolutely didn't turn it on when you did sham? Is that what happened?
We didn't turn it on with the sham.
Okay.
The fan. Because you can see
I know the fans go.
But the fan is still on, so they can hear the sound.
Yes.
They cannot differentiate based on the sound. So we find the waiting area that we deliver the photobiomodulation. Basically, there is no mirror around. So
right.
They have no way to know that.
Okay, that's what I was curious about. Thanks. Thank you.
Thank you all. This is an amazing discussion. Thank you, Phoebe. That was a very unique contribution to the field. Absolutely. very exciting. Thank you all, and nice seeing you, and to be continued.